All right, let's talk about a diagnosis that can be a real head-scratcher, even for experienced doctors: cutaneous leishmaniasis. This is one of those classic great cases that you'll definitely see on rounds or on your exams, so knowing the approach cold is absolutely key. Let's dive right in.
So, picture this. A patient walks into your clinic. They just got back from a trip, and they've got this skin lesion that just won't heal. The weird thing, it doesn't hurt, but it's been there for weeks, maybe even months. So, what's running through your head? A bacterial infection? Fungal? Maybe a weird spider bite? Well, with that travel history, leishmaniasis has got to be high on your list.
Now, a really helpful way to think about leishmaniasis is not as just one disease, but as a whole spectrum of disease. And what determines what it looks like? It's all about the patient's own immune response to the parasite. You know, it's a lot like leprosy in that way. At one end of the spectrum, you've got a super strong immune response trying to wall it off, and at the other end, a really weak response just lets it spread.
So, right in the middle of that spectrum is the classic presentation you are most likely going to see. It's called localized cutaneous leishmaniasis, or LCL. It usually kicks off as just a small pink bump, what we call a papule. But over a few weeks it gets bigger, the center starts to break down, and it turns into this really characteristic painless ulcer with a raised, firm, or indurated border. That border, that's your first big clue.
You know, just asking one simple question, where did you travel, can give you a huge visual hint right there at the bedside. If your patient was in Africa or Asia, the Eastern Hemisphere, you might see this dry, crusty, almost scaly cap on the ulcer. But if they were in the Americas, you're much more likely to see a thick, kind of gooey, whitish-yellow material covering it. It's a small detail, but man, it's a powerful clue.
Okay, but what about the extremes of that spectrum? Well, they look completely different. If someone has a really, really strong, almost over-the-top immune response, it can lead to this devastating mucosal leishmaniasis. The parasite is hard to find, but the tissue destruction is just awful. On the flip side, with a very weak immune response, you get something called diffuse cutaneous leishmaniasis, where the skin is just loaded with parasites, forming these nodules all over the body.
Okay, so you're starting to see the pattern, right? Your spidey senses are tingling. Now it's time to really build your case. And this is where your history and physical exam skills are crucial for taking this from just a possibility to a real probability.
Seriously, the history is everything here. Of course, you'll ask about travel, but you got to dig deeper. Were they in the countryside? Were they outside around dusk or dawn? Because that's prime time for the sandfly vector. You should also ask if anyone else on their trip got sick. And don't forget about that incubation period. This isn't something that shows up the day after a bite. We're talking weeks to months later.
So when you're doing your exam, here's what to zero in on. Look for lesions on exposed skin: face, arms, legs, places sandflies can easily get to. Then, feel that border. Is it firm? Is it raised? Look closely for little tiny bumps, satellite papules, around the main ulcer. And please don't forget to feel along the lymphatic channels draining that area. Sometimes you can feel these little bumps under the skin, a sign of what we call sporitrichoid spread, which is a huge clue.
All right, at this point, Leish is probably sitting at the very top of your differential. But you know the deal in medicine. Suspicion isn't enough. You need proof. So the next step is getting that tissue sample to the lab for confirmation.
And listen, how you get that sample is absolutely critical. Don't just scrape the dead gunk from the middle of the ulcer. No, you've got to clean it, gently get rid of any crust, and then take your sample, whether it's a scraping or a punch biopsy, from the most active part of the lesion. And where is that? It's that raised, firm border. That's where the parasites are living. Ideally, you want to send that tissue for the whole shebang: histology, culture, and PCR.
So, what exactly is the pathologist searching for into that microscope? They're hunting for the Leishmania amastigote. It's this tiny, oval-shaped organism hiding out inside our immune cells. You'll see its nucleus for sure, but the dead giveaway, the feature that screams Leishmania, is this tiny little rod-shaped dot called the kinetoplast. See that? And you've got your diagnosis.
Okay, then there's culture. You take the tissue, put it in a special liquid media, and the amastigotes actually transform into their swimming, flagellated form called promastigotes, and they start to multiply. The huge plus here is that once they grow, you can figure out the exact species. But the downside, it's really slow. We're talking weeks, and it's super easy for bacteria from the skin to contaminate the sample and ruin the whole thing. And that, of course, brings us to PCR. This is pretty much your gold standard for sensitivity. It's amazing. It doesn't need to see the organism, and it doesn't need to wait for it to grow. It just directly finds and amplifies the parasite's DNA. The sensitivity is fantastic, even if the lesion is old or there aren't many parasites to begin with.
So let's just break that down real quick. Histology is fast, but you might miss the diagnosis if the parasites are few and far between. Culture is awesome for telling you the species, but it's slow and gets contaminated easily. PCR has the best sensitivity, hands down. So, what's the big takeaway here? If you can, send your sample for all three. You'll maximize your chances of getting a definitive answer.
But here's the thing. Even after you get that positive result, you are not done. Not by a long shot. Finding out the exact species of Leishmania isn't just for bonus points. It has massive implications for how you treat your patient and what their future looks like.
Let's take a perfect example. Say the lab calls you back and says the PCR is positive for Leishmania brasiliensis, which is common in South America. That should set off alarm bells. Why? Because we know this specific species carries a pretty high risk of spreading to the nose and mouth and causing that destructive mucosal disease, sometimes years after the skin sore is long gone. That is critical information you have to have.
All right, let's bring it all home and wrap up with the most important, high-yield points. This is the stuff you'll want to tuck away in your brain for when you're on the wards.
So, here's your diagnostic checklist. First, traveler, chronic ulcer, think Leishmania, always every time. Second, remember, it's a spectrum. What you see depends entirely on the immune response. Third, use your clinical skills. A great history and physical can get you most of the way there. Fourth, when you biopsy, where do you go? The active, raised border every single time. And finally, use a three-pronged attack: PCR, histology, and culture to nail the diagnosis. And I want to leave you with this final thought to chew on. You've done the hard work, you've made the tough diagnosis, but the next step is just as vital. Why does knowing if it's L. tropica versus L. brasiliensis completely change the conversation you're about to have with your patient? That's the bridge from diagnosis to management, and that's what makes this stuff so important to know.